So I'm talking about diabetes, nutritional status, and the role of vitamin D in primary total knee arthroplasties. These are my disclosures, none of which are relevant to this talk. So the prevalence of diabetes for patients undergoing total knee replacement ranges anywhere from 8% all the way up to 22-25%. There's increased prevalence of diabetes amongst patients undergoing arthroplasty, and it's probably related to the increasing life expectancy, overall obesity rates, and overall diabetes rates as well. So patients with diabetes, as Dr. Riaz mentioned, they require special attention and management because of the increased risk of complications, including infection, poor wound healing, and cardiometabolic issues as well. So there's a lot of published data on higher risk of complications in diabetic patients undergoing total knee arthroplasty, and a lot of this focuses on uncontrolled diabetes. So this was a study out of University of Texas, which basically looked at the impact of diabetes on a 90-day episode of care after total knee arthroplasties in the elderly population. And what they found was that readmission rates were a lot higher in diabetic categories compared to the uncontrolled diabetic group has a substantially higher risk of readmission compared to the controlled diabetics and the non-diabetics. In this study out of Finland, they found that diabetes and morbid obesity increased the rates of periprosthetic joint infection following primary hip and knee arthroplasty. This one, Dr. Riaz mentioned as well, a study out of University of Utah showed that type 1 diabetes compared to type 2 had a slightly increased risk of prosthetic joint infection as well. These studies are out of Delaware and University of Texas as well that showed that uncontrolled postoperative hyperglycemia is a stronger risk factor than anything else. So it's more than just the history of diabetes. It's the fact if somebody's uncontrolled that is the main problem. So how do we screen for diabetes? So the primary ways that we look for is fasting blood sugar, but that can sometimes be a little bit more difficult to assess unless the patient is recording their fasting blood sugar in the morning and nighttime every day for the past week prior to surgery and post-operatively as well. It's a little bit harder to manage, but on the day of surgery, if their fasting blood sugar in the morning is 300, they're probably not the most controlled. Hemoglobin A1C we'll touch on, and fructosamine is a newer lab study that's been recently published over the past couple of years that has gained some traction. We'll touch on it in a minute as well. So first, the fasting blood sugar, pre-meal blood sugar should be anywhere from 90 to 130. At nighttime, it should be anywhere from 100 to 140. So A1C, over the past couple of years, there's been increasing literature on what the optimal threshold is. The A1C, as everybody knows, is a nice summary of diabetic control over the past 3 months. So when we looked at thresholds and what we told our patients that they should strive for, there was not a huge consensus. So this was a multi-center study out of Rush, NYU, Rothman, Duke, and it should have been an award paper. But anyway, so they found that 7.7 was a good threshold. Anything above a 7.7, there was a drastically increased risk of complications. So other studies show a little bit higher levels. So overall, in the U.S., the clinical practice guidelines do suggest anywhere below 8 is acceptable. My personal threshold is anywhere around 7.5 and lower. So the problem with A1C, like I mentioned, is it's a summary of how someone's diabetes is controlled over the past 3 months. So maybe the first 2 months they were doing really, really well, but the last couple of weeks prior to surgery, they kind of fell off and had a lot of matai and went to a lot of davats and kind of fell off their nice diet regimen, and they kind of became uncontrolled. And that's what we found is a little bit more problematic than the overall 3 months. It doesn't give a good story of how a patient is doing closer to the time of surgery. So if someone has an A1C of 7, but their fructosamine level is very elevated, I think that means a little bit more. So 2019, the group out of NYU and Rothman, they had this award paper that looked at fructosamine levels, and what the fructosamine level does is it gives you a better assessment of diabetic control over the past 2 weeks. And what they found is they found this threshold of 290 or 293 to be a good assessment. Anything above 290, above 300, there was a markedly increased risk of infection and complications compared to those that had levels below than 290. So for me, if a patient has an A1C of 6.8, but their fructosamine level before surgery is 400, they're automatically canceled because I know around the time of surgery, they're pretty uncontrolled. Conversely, if someone's A1C is 8.5 and their fructosamine level is 250, I'll strongly consider proceeding with surgery for those same reasons. So I think fructosamine does have a really, really good predictive role in this situation. The one problem with fructosamine is it's a pretty expensive test, and it's usually a send-out test. It's usually not done at the hospitals, especially in the US, and it takes about 5 to 7 days to result. So you just have to time that accordingly. So moving on to nutritional status, malnutrition is defined as an inability to achieve metabolic and nutritional requirements. Preoperative malnutrition has been reported to be as high as 50% in patients undergoing surgical procedures, and it really affects 2 out of every 3 patients in major surgeries. So when we're looking at patients undergoing primary and revision total joint arthroplasty, anywhere from 8 to 50% of patients are reported to have lab markers suggestive of malnutrition. And the reason why this is so important is because malnutrition prevents wound healing, it increases risk of infection, increased risk of complications. So as Dr. Riaz mentioned, there's a number of lab values that suggest or are indicative of nutrition, and it's more than just one value, it's a conglomerate or a combination of all these values. So albumin, prealbumin, total lymphocyte count, transferrin hemoglobin as well. Albumin has kind of been the gold standard for a surrogate for nutrition. Similar to albumin, the depletion of serum prealbumin demonstrates a relationship between malnutrition and systemic inflammation as well. The reason why prealbumin is a little bit better in my mind is because it's a little bit more of a sensitive marker, and it's really sensitive to acute nutritional change because it has a shorter half-life. So similarly, if someone has a relatively normal range for albumin, but their prealbumin is very low, I know there's something more acute going on in, that we have to dive a little bit deeper in terms of why that is. These are a few studies from my mentors at in Cleveland and New York as well that kind of had a detailed review and guideline in terms of nutritional assessments and interventions. So the moral of the story with diabetes, even vitamin D and nutrition is it gives you a sense if a patient is ready for surgery. So like Dr. Riaz mentioned, it's more than just having a clearance. You want these patients optimized. If these lab values are not optimized, you have a higher risk of complications. So vitamin D is very important for bone health and overall systemic inflammation as well. It regulates the amount of calcium in the body. So studies have shown that low levels of vitamin D can cause increased muscle pain and joint pain. So in patients facing joint replacement surgery have a higher rate of infection in those that are vitamin D deficient. There's higher rates of MUAs and increased risk of cardiac issues as well postoperatively. So there's a huge, these are basically the levels that we kind of look at. The problem with vitamin D is we're talking specifically about 25 hydroxyvitamin D. There's a few different markers that you can check from the blood, but this is the one that's really indicative if you're truly vitamin D deficient or not, because this is the one that can be replaced. So all in all, preoperative patient optimization is the goal here. Value-based care in the Western Hemisphere has really kind of been the push and the focus. Basically value is quality over cost. But what's important to highlight over here is outcomes and a patient experience, which determine quality over over how much it costs to deliver those services. So if you're not optimizing your patients and you're having increased risk of complications, you're decreasing your outcomes, you're having worse quality, you're increasing your cost, and you're thereby delivering decreased value. So you overall want to increase your value, and patient optimization is at the forefront of that. Thank you.